Hi, Dr. Rossi.
Hi, Gabby. Hi. How are you?
Hi. Good, thank you. Thanks so much, everyone, for joining. As you can see by the title of this live, Dr. Rossi will be covering the topic of endometriosis and IVF. So before we get started with the questions, Dr. Rossi, would you like to give a brief introduction on the topic?
Yes, so thanks to everyone for joining. So I briefly explain what endometriosis is, and then we'll be discussing mainly impact of endometriosis in IVF treatment. So the endometriosis means that, so essentially the endometrium, which is a lining of the uterus, normally should be located only inside the uterus. So lining of the uterus is like carpet. This is the place where the embryo implants and grows. So in endometriosis, this lining of the uterus ends up outside the uterus. So endometrium is a glandular tissue and it has got stem cell properties. Stem cell means whenever there is a stimulant, it grows. So stimulant for endometrium is estrogen and progesterone. So let us say if you have endometriosis, you have a lining of the endometrium, which is endometrial cells, ends up outside the uterus. If the same cells end up in the wall of the uterus, we call this adenomyosis. Essentially, it's the same thing, but the location of endometrial cells are in the wall. That's adenomyosis. And if it's outside the uterus, that's called endometriosis. What happens in endometriosis? These cells end up in the pelvis, which is outside the uterus. It can be on the bowel, it can be on the bladder, it can be on the pelvic side walls, on the back of the uterus, on the ovaries, fallopian tubes. So wherever they are, and they get stimulated with a natural estrogen. So what happens in natural menstrual cycle after menstrual period when estrogen is going up because of growing follicle, which contains egg, produce a lot of estrogen. So that estrogen prepares endometrial lining inside the uterus for implantation of embryo. At the same time, the endometrium, which is the endometrial cells outside the uterus, start getting activated. So then after ovulation, ovulated follicle start producing progesterone hormone. So after progesterone drops, if pregnancy doesn't happen, then progesterone drops, then you have a discharge of endometrium. So when the discharge of endometrium happens inside the uterus, you have a detachment of this one layer of endometrial lining, and that comes outside as a menstrual period. The problem is in endometriosis, those cells which is inside the abdomen and pelvis also get detached and cause discharge and localized discharge. Of course, they can't get out. There's no orifice to get out. They get stuck there. So what happens is then immune cells come, try to remove this abnormal ectopic cells. Ectopic means misplaced cells, and they start fighting with those cells inside those tissues in the pelvis. And this fight between immune cells and endometrial discharge all cells causes inflammation. So inflammation happens when there's immune cells are fighting with the abnormal cells. So this causes swelling and in localized area in inflammation. That inflammation causes all the symptoms of endometriosis. Let us say because of inflammation, whole area gets swollen. If you have nerves passing by nearby, and those nerves get entrapped inside the swollen tissue and can cause pain. So this is why one of the main symptoms of endometriosis is pelvic pain. Pain in endometriosis happens because of increased pressure, because of inflammation. So especially this pain gets worse during menstrual period because during the discharge of those fluid, you have increased swelling and increased irritation of those nerves in the pelvis. It can cause menstrual period pain. We call dysmenorrhea. So also all the symptoms like scar tissue formation happen because of this fight between immune cells and old endometrial cells. The problem is those cells can't be removed. Your immune system gradually removes them slowly, but by the time it manages to remove all the damaged dead cells, then new discharge happens. Then immune system cannot catch up. If cannot catch up, this cells get deposited, which means get accumulated. If they get accumulated in the ovary, then we call it chocolate cyst. So if it gets accumulated in the pelvis, it causes a lot of scar tissue. We call adhesion formation. So that scar tissue can cause infertility. Why? Because when you have a scar tissue formation on the fallopian tubes, like ovaries, which means fallopian tube is not mobile, it cannot catch a released egg from the ovary, which means fertilization doesn't happen because whole fallopian tube is stuck within the scar, and egg, you're releasing the eggs, but the eggs not getting caught by fallopian tube. So, and those whole inflammation also doesn't create perfect environment for eggs to survive after it's been released by the time it's caught by fallopian tubes. So these are the main cause of infertility in endometriosis. And of course, if you have severe endometriosis, which is stage 3, stage 4 endometriosis, you can have something called frozen pelvis. Frozen pelvis means everything is jumbled up in one, like your bowel, bladder, uterus, ovaries, fallopian tubes, whole thing. You cannot, when you put the keyhole surgery in laparoscope, you can't distinguish what is what. So which means there's no good condition for ovulation, and or even if ovulation happens, it isn't good condition for fallopian tubes to catch the eggs and create the embryos and create good environment for implantation. So essentially, the endometriosis is a generalized inflammation of pelvis driven by estrogen and progesterone. So here the inflammation main driver of the inflammation is a cyclical increase of estrogen in the middle of cycle during the ovulation, and discharge of endometrial cells after progesterone drops during menstrual periods. So two things, like ovulation flares endometriosis, then drop of progesterone menstrual period causes discharge, localized discharge. So yeah, so this is the cause of the mechanism of endometriosis. Unfortunately, endometriosis is common. Generally, 10-15% of women generally have endometriosis. Essentially, 1 in 10, 1 in 6 women have endometriosis. And the chance of getting endometriosis increases with the age because of continuous exposure to cyclical estrogen and progesterone change over time. So gets more and more common after the age of 30, 35, 40. So it's more common with increased fertility age. And in patients who have infertility, the prevalence or rate of having endometriosis high. So 25-50% women who have infertility are diagnosed with endometriosis. Why? Because they usually coexist. Endometriosis can be one of the causes of infertility. Yeah, so this is overall endometriosis and role of endometriosis in infertility. And on today's live stream, we will be mainly focusing on impact of endometriosis to fertility in IVF. Of course, endometriosis can cause a lot of various different problems, mainly pelvic pain, heavy periods, difficulty with having intercourse because of pain during intercourse, multiple different problems. We cannot address all. That's a very huge topic, but we will be focusing on role of endometriosis in patients undergoing IVF treatment, and a lot of things I will be talking today will be related in the patients who is undergoing IVF treatment.
Thank you so much, Dr. Asti, for providing such a detailed explanation on endometriosis and also its correlation to infertility. Could you please explain how to diagnose endometriosis?
Yes, so the endometriosis we diagnose first based on the symptoms. We ask patients if they have a symptoms of endometriosis, which is pelvic pain, so constant pelvic pain, which gets worse during menstrual period, and pain during intercourse, So these are the pain symptoms of endometriosis. Also, endometriosis can cause heavy period, especially if it coexists with adenomyosis. In adenomyosis, uterus gets swollen, big, and then the patients have a bigger surface volume of endometrium, which is endometrial lining, and they tend to have a heavier period. So these are some of the symptoms of endometriosis, and also infertility itself is one of the symptoms of endometriosis. So like we said, 25 to 50% of women with infertility have endometriosis. So just simply the fact that patient has endometriosis doesn't necessarily mean that's actually cause of infertility. The actual cause of infertility may be different, but endometriosis may be coexisting problem. And a lot of patients, endometriosis itself doesn't cause infertility. It can reduce the fertility, but is not the main cause. There's additional cause for the infertility. So maybe low egg reserve or female age, maybe sperm parameters, or blocked fallopian tubes. There could be different causes, but in some patients, actual endometriosis is the cause of infertility, especially in patients with stage 3, stage 4 endometriosis, and patients who have ovarian endometriosis, like chocolate cyst, and patients who have adhesion scar tissue formation around the fallopian tubes. So for these patients, actual endometriosis may be the cause of infertility. This is why we take a history to diagnose. We ask all about all the symptoms, and also infertility itself. In patients with infertility, we suspect they may have endometriosis. So then next level of investigation is pelvic ultrasound scan. So you can have two different type of scans. Simple pelvic ultrasound scan, where you just do full scanning, check if there's any chocolate cyst, which is the ovarian endometriosis, we call endometrioma, whether there is any significant endometriotic nodules in the pelvis. So, but the simple scan can easily miss endometriosis, because you may not be able to see the nodules properly in simple scan. But in deep pelvic ultrasound scanning, which is specifically designed to detect severe endometriosis, you usually pick up the endometriosis. And deep pelvic scan, of course, you scan ovaries, and if there's any chocolate cyst, you should be able to pick up. And also you scan inside the pelvis, and you can check if there's any endometriotic nodules. Certainly, deep pelvic scan can diagnose stage 3, stage 4 endometriosis. Stage 3, stage 4 means you have a lot of scar tissue in the pelvis. Stage 1 endometriosis is very mild endometriosis, and it's very superficial, and you may miss even in deep pelvic scan. Stage 2, some nodules you can pick up on deep pelvic scan. In some patients, especially if they have a stage 3, stage 4 endometriosis, if you're planning to do laparoscopy, they may need to do MRI to have a proper investigation of state of endometriosis before they do laparoscopy. So history, ultrasound, and MRI. But the gold standard for diagnosis of endometriosis is, of course, laparoscopy. Because on laparoscopy, you directly visualize the pelvis, and you check systematically all areas of the pelvis to check if there is endometriosis. So you can diagnose whether there is endometriosis. Second, you can stage whether it's stage 1, 2, 3, 4, and you can tell where the nodules are. And at the same time, of course, you can treat the endometriosis by removing, excising those endometriotic cells and endometriotic nodules area with endometriosis. So laparoscopy, of course, is a gold standard for diagnosis of endometriosis.
Thank you so much, Dr. Asti, for explaining how to diagnose endometriosis, also how to stage endometriosis. You mentioned there that you can treat endometriosis through a laparoscopy. Is that the only form of treatment for endometriosis?
Yes, so in terms of endometriosis treatment, really you depends on the symptoms. So for pain symptoms, of course, best treatment of endometriosis is excision, which is removal of endometriosis, and using various pain protocols manage the chronic pelvic pain, and of course you do hormonal treatment. So, and you can do down regulation of ovaries. Essentially, but here we are mainly will be discussing the treatment of endometriosis in patients undergoing IVF. So in IVF, we first of all we need to know what impact endometriosis can make to the patients who's undergoing IVF. It really depends on location of endometriosis and severity of endometriosis. So if you have an endometriotic cyst, chocolate cyst, we usually recommend not to treat the endometriosis, not to remove the endometriosis by doing surgery. Why? Because when you remove the chocolate cyst, you remove sleeping eggs, you reduce the egg reserve, and which can actually make things worse. But in patients with very large chocolate cysts, especially if they have a lot of pelvic adhesions where the ovaries are not accessible, yes, we do recommend doing excision or surgery to remove or maybe drain the chocolate cyst to create some window where we can do IVF, egg collection, and create embryos. So that really very much depends on severity and type. Essentially in IVF, main impact endometriosis can make is if it's severe, it can push ovaries very high up. It may make it very difficult to access the ovaries. When you do ultrasound for monitoring or ultrasound for egg collection, ovary may be very high. So this is one problem endometriosis can cause in IVF. Second problem endometriosis can cause is reduced implantation. Usually stage 1 and stage 2 endometriosis don't affect implantation significantly and you don't need to do any treatment. Stage 3, stage 4 endometriosis, we do transfer embryos. If they have a repeated implantation failure, we recommend doing endometriosis surgery or down regulation of endometriosis using, for example, Prostab, Zoladex, Lupron type medications. So really, as we said, 25 to 50% of patients undergoing IVF have endometriosis. It doesn't mean all these patients need to have a laparoscopy or surgery. So most patients with endometriosis undergoing IVF do not need surgery. And most patients, most probably 80, maybe even 90% of patients with endometriosis undergoing IVF do not need any laparoscopy, any surgery, even diagnostic procedure to establish endometriosis, and they get successful pregnancy with IVF. So, but in a small group of patients with where the ovaries are not accessible because of severe endometriosis, or they have a multiple large chocolate cyst occupying whole space on the ovary, and this why not allowing us to do proper ovarian stimulation. So, and also patients who have the repeated implantation failure because of stage 3, stage 4 endometriosis, these patients benefit from the surgery. So the decision in terms of patients whether they need surgery or not for endometriosis is very much individualized. So we cannot say the blanket rule for everyone and get thousands of patients to do operation unnecessarily, because operation itself is not free of risk, especially if stage 3, stage 4 endometriosis, it can involve even bowel surgery. It can make things much worse. So a lot of time we achieve successful pregnancy using IVF, and some patients we do medical treatment of endometriosis, which is down regulation of ovaries for 3 months, 4 months. That will relieve the inflammation. It opens implantation window. Once you achieve successful pregnancy, then progesterone produced from the placenta will keep endometriosis suppressed. If this severe endometriosis cause problem in the future, after they complete their family, once they have the kids, then they can have a surgery for endometriosis. So simply doing surgery for everyone is not right thing in IVF. So we are very selective and very individualized. We do provide individualized advice in patients who have endometriosis. Like I said, 25 to 50% of women undergoing IVF have endometriosis. Most patients get successful pregnancy without actually surgical treatment of endometriosis. But actual most effective treatment is excision, which is removal of endometriosis by doing surgery.
Thank you so much, Dr. Asti. There you definitely had a clear emphasis that majority of women who do have endometriosis don't necessarily have to undergo surgery for success in IVF, but that small portion that might require, what is the criteria that would require your recommendation for undergoing surgery for success in IVF treatment?
Essentially, let us say, for example, if patients have a difficulty with ovarian, essentially in IVF, we need, or even in fertility, natural conception, or any fertility treatment, essentially we need to solve two problems. One is the creation of high-grade embryos. And first problem, so second problem is achieving successful implantation. So you need to go through two hoops. One is the creation of high-grade embryos, second is implantation. So it really depends, if a patient has endometriosis, it really depends on whether this endometriosis causing achieving any of these goals. Generally, endometriosis does not cause any problem with egg quality. So the thinking that endometriosis reduces egg quality is misconception. So eggs grow in their own very protected environment, and directly ovaries get blood supply from aorta, which is the main blood vessel, and all this endometriosis doesn't reduce their blood supply. And overall, we do IVF, like we said, almost 50% of our patients were saying that have endometriosis, and every day we treat patients with endometriosis, including severe endometriosis. Essentially, it does not affect egg quality or egg quantity. So this is by far, to solve the first problem, we need a good egg quality, quantity, good sperm quality and quantity. Provided endometriosis is not causing an obstacle towards that, we do not need to do surgery. So this is why most patients easily create high-grade embryos with endometriosis. This is the first requirement. Second is implantation. Again, mild endometriosis, stage 1, stage 2 endometriosis doesn't affect implantation. So the impact of distant mild endometriosis, where you have some inflammation, distant mild inflammation and pills, doesn't significantly impact implantation. Yes, adenomyosis does. Why? Because adenomyosis is inflammation of the uterus. Directly, this endometrial bed where embryo implants is inflamed. But in endometriosis, this inflammation is distant, maybe in the pelvic side wall, maybe in the bowel. So that doesn't significantly impact inflammation. But severe endometriosis, stage 3, stage 4 endometriosis, may cause more inflammation, generalized inflammation. It can reduce implantation. So not as much as adenomyosis. In adenomyosis, implantation chances reduced by 25 to 50%. Let us say you have a patient who's 30-year-old, has a 40-45% chance of implantation with a high-grade embryo. With adenomyosis, their chance can be reduced maybe to 20-25%. With endometriosis, severe endometriosis, their chance may be reduced by 10-15%. Yes, they don't have a 40% chance. They may have 35% chance. If they can easily create high-grade embryos, they can get successful implantation. That's our objective, yeah? So in most patients, this is why we do not need to do surgery, and we achieve successful pregnancy. But in patients where we are having difficulty with ovarian stimulation because of severe endometriosis, stage 3, stage 4 endometriosis, where ovaries entrapped inside the scar tissue, cannot grow follicle, yes, we need a surgery. So ovaries have to be free to grow follicle easily. So, and in patients with stage 3, stage 4 endometriosis, and a lot of patients with stage 3, even stage 4 endometriosis, we successfully do IVF and get eggs and embryos easily. Why? Because the ovaries, when stimulated, they get swollen and they keep creating space around them and keep producing follicles. If they do repeated cycles, it becomes easier and easier. But in some patients, the adhesion is so dense and ovary is so high, after 1 or 2 cycles, we assume that, okay, so this patient has good egg reserve, ovary is not responding as well, or not responding at all, or not accessible, it's so high. In this patient, actually, we need to do endometrial surgery. Yes, it's extensive surgery, there's the risks, but here, this is our only option. So then we do recommend doing endometrial surgery before doing more egg collection cycles, IVF cycles. So very much the decision is individualized. So putting blanket rule for everyone to do laparoscopy unnecessarily with its own risks. Of course, it's time and cost and health risks and delay. let us say if somebody you put on recommend doing laparoscopy unnecessarily because of endometriosis, they wait on public system maybe 18 months. Their age is already 39. By the time they have endometrial surgery, their age is 41. You defeated the purpose. Actually, they made more harm because the whole egg reserve and egg quality dropped, and that actually time was more important than doing surgery. So that's why we cannot make a blanket rule. We should make very individualized decision depending on whether this endometriosis going to impact creation of high-grade embryos and achieving implantation. If they do, how much impact is causing, minimal impact or moderate impact or significant impact. Then of course depends on availability of the surgery depending on healthcare setting in different countries, have different settings. So yeah, this decision is very much individual. Like I said, a lot of patients, probably most patients with endometriosis doing IVF have successful pregnancy without doing any surgery.
Thank you so much, Dr. Asti. That was very insightful. That was my final question for this live. So before I conclude the live, is there any final points you'd like to make on the topic of endometriosis in IVF this evening?
So yeah, general endometriosis is unfortunately common. Patients who are doing IVF should not get alarmed that they have endometriosis. So yes, we take this into account when we make decisions. And like I said, most patients with endometriosis doing IVF have successful pregnancy.
Thank you so much, Dr. Asti. I really enjoyed that as a female with endometriosis myself. That was extremely insightful, and I'm sure that your followers definitely gained a lot of knowledge there. So, as always, thank you to those that jumped on. The screen recording of this live will be published to Dr. Asti's social media account, so you can review there and comment below if you have any questions. The topic of our next live will be egg collection. So, please jump on that one tomorrow evening if you would like to learn more about that topic. Thank you so much, Dr. Asti.
Thanks, Gabby, for organizing today's live stream. Thanks, everyone, for joining. Yes, we'll be posting the videos on Instagram, TikTok, and YouTube.
Thank you. Bye, everyone.
Thank you.